Okay, good afternoon. So today we are going to continue with the nervous system, and to be specific, we will deal with the sensory system. Last time we started with the general sensations, and today and the lecture for next week will be about the special senses. So the general senses that we were dealing with last time, they included like somatic senses, tactile, thermal, pain, proprioception. Remember those pathways that I mentioned? For example, for proprioception, it was the posterior column medial lemniscus pathway. For the somatic senses, for the thermal and pain, it included the spinothalamic tract, for example. And also, the general senses include general sensations that arise from the viscera. The receptors of these senses, as we have seen last time, they were either very simple, like, for example, free nerve endings that you can see them here, or they are a little bit encapsulated, but they are not that much complicated in the special sense. And they are present all around the body. But in special senses that include specific sensations like the smell, taste, vision, hearing, and equilibrium, they are housed in very complex sensory receptors, as we will see today, especially for the eye, for the equilibrium, for the ear. They are so complex and they are restricted to certain places in the body. They are not present all around the body. So I will start today with olfaction, then taste, then vision, and we will leave the hearing and equilibrium for the next session. Starting with the olfaction, probably we have mentioned that before, that the mucosa of the nose, there is a certain part of the mucosa which is called the olfactory mucosa, and this is present in the upper part of the nose. About only 1/5 of the mucosa of the nose is olfactory mucosa. Present in the upper part, it lines this plate of bone, which is called the cribriform plate of bone. Remember the skull and the cribriform plate of the ethmoid bone that has so many perforations. Here, this is the olfactory mucosa. The remaining part of the mucosa of the nose is actually, it is respiratory mucosa. It is for respiration. It is not for olfaction. It humidifies the air, warms the air, filters the air, but is not for olfaction. It is only the upper part that is for olfaction. That's why when we want to smell something, we usually sniff in order to create currents of air that will go up into the olfactory epithelium. This olfactory epithelium, you can see a diagram here of olfactory epithelium. You will find that there are olfactory sensory cells or olfactory receptor cells. Olfactory receptor cells. These are bipolar neurons, and you can see that they have an enlarged dendrite here, which has multiple hairs, which are cilia, and these contain the receptors. These receptors are chemoreceptors. Remember the types of receptors that we mentioned last time, like chemoreceptors, baroreceptors, nociceptors, proprioceptors. These are chemoreceptors. And so they need the substance that has an odor to dissolve in order to affect these cilia. And usually they dissolve in the mucus. This mucus is produced by glands. So there are in the mucosa as well, there are, we call them olfactory glands. These secrete mucus, and this mucus helps to dissolve the chemical substance that produces the odor. In addition to these sensory cells, there are supporting cells. So you will find that there are supporting cells here. They are columnar cells. They support, they nourish, they insulate those dendrites. Okay, and there are basal cells. You can see them here. They are small cells, short cells. They're called basal cells. They have the ability to multiply and replace the olfactory receptor cells. This might be something unusual in the nervous system. We mentioned that the neurons, they cannot be replaced, but this is another place in the nervous system where these neurons, they will be replaced. So for every month, they are going to be replaced with new neurons, the olfactory receptor cells. Do you remember any other place in the nervous system that was mentioned before where neurons can multiply and replace themselves? We mentioned that when we were dealing with the limbic system, the region that is responsible for memory. Okay, So these areas, the hippocampus, again, it has some cells that can multiply and replace themselves. So what's going to happen is that the axons of these olfactory cells, the bipolar neurons, the dendrites receive the stimulus, it's a chemoreceptor, and then the axons, they will bundle together and they will form about like 40 bunches of axons that pass through the cribriform plate. That's why the plate has multiple openings like a sieve. And then they will go into a structure here called the olfactory bulb, where a second group of neurons will begin, and they will send their axons to the olfactory cortex, directly to the olfactory cortex. There is no thalamus here. Remember that the thalamus receives all types of sensation. It's a hub, except olfaction, so you can feel the sense of olfaction without synapsing in the thalamus. These fibers of the olfactory bulb will go directly to the thalamus. Some of the fibers might go to the limbic system, and these are responsible for the memories and emotional responses to that the odors might evoke. Okay, so there are connections with the cortex, with the sense, for conscious, for perception of the olfaction, and with the limbic system as well. So far about olfaction, it is not that complicated, and the olfactory nerve is classified as the first cranial nerve, CNI. Okay, now we go to the second sense, special sense, and this is the taste. Again, this is a chemical chemoreceptors. Chemoreceptors are present in taste buds. We have 5 classes of sensory or taste stimuli: the sour, the bitter, the sweet, salty, and the umami. And these are received at gustatory or taste receptors, which are present mainly on the tongue. So this is the tongue. We are looking at the tongue from above. And some of them are present on the epiglottis, the lid that covers and closes the respiratory passages and protects them from passing the food and fluid passing into the larynx. We're going to study it in more detail later on, but it has some taste buds on one surface, as well as the soft palate. The roof of the mouth, the soft palate, also it has some taste buds, but the main taste buds are located on the tongue. Look at the tongue. I mean, you are probably, when you stick your tongue in front of the mirror, you are probably familiar with this view of the tongue, the anterior 2/3 of the tongue. But the tongue has another 1/3 here, which looks like it has a cobblestone appearance. Here the mucosa is, underneath the mucosa there are lymphoid follicles for protection. Most of the follicles that contain taste buds are present here, and we have like papillae processes arising from the tongue, and they are called according to their shape. So we have, for example, here the vallate papillae. Vallates, they are very big. You can see a section in a vallate papilla. It's big one. It has a ditch around it. And in this ditch or groove, there are the receptor cells. The taste buds are located. So they are located at the junction between the anterior 2/3 and the posterior 1/3 of the tongue, the circumvallate papillae. And then we have the foliate papillae on the side of the tongue. And then all over the tongue, there are other papillae, which are fungiform papillae. They look like a mushroom. You can see them in front of the mirror. You can see that there are multiple of these fungiform papillae on the anterior 2/3 of the tongue. But the most common papillae which you will find on your tongue, they look like hairs, and they give your tongue the velvety appearance. These are called the filiform papillae. They are the most common papillae, but they do not contain taste buds. Why do we have them? Is that to increase the friction between the bolus of food and the tongue, so that the tongue can move the bolus of food from one side to another. But they are not for taste. So the filiform papillae, although they are the most numerous on the tongue, but they have no taste buds. The others, the fungiform, the foliate, the circumvallate, they have the taste buds. And this is how the taste bud looks like. This is a diagrammatic view of the cells. Again, we have gustatory receptor cells. These cells, they have microvilli that appear on the surface through a small pore, as you can see it here, and they have the chemoreceptors, and then the substances which will produce a taste sensation will dissolve in the saliva and the mucus and can stimulate these cells, the gustatory receptor cells. On the other side, the gustatory receptor cells, they synapse with the dendrites of first order taste neurons. These cells are continuously replaced, these gustatory receptor cells. They are not neurons, they are specialized cells, and they can be replaced. So that's why if you drink a very hot coffee, sometimes you will lose the taste for like a couple of days, but then after that, because these cells are going to be replaced, so you will regain the sensation of taste in a short period of time. So they synapse with first order neurons of the nerves that serve for the taste. In this taste bud, it is not only these gustatory receptor cells are located, but you will expect that there are supporting cells. Same idea like in the olfactory epithelium, there are supporting cells, and there are basal cells. These basal cells, they multiply, they form supporting cells. The supporting cells multiply and form the gustatory receptor cells. The nerves that are involved in gustatory pathway, we have 3 nerves, but the main nerve is the facial nerve, the 7th cranial nerve, and it receives the gustatory impulses from the anterior 2/3 of the tongue. From the posterior third of the tongue, it is received by the 9th cranial nerve, which is the glossopharyngeal nerve, and from the epiglottis and the palate, it is received by, taste sensation is received by the vagus nerve, the 10th cranial nerve. All these, they relay in a nucleus, another collection of nerve cell bodies, which is located in the medulla oblongata, and then from the medulla oblongata, they relay in the thalamus, like any other type of sensation, except olfaction, and then from the thalamus, the third order neurons will project to the sensory cortex, which is usually located in the parietal lobe. Some of the fibers will relay in the hypothalamus and in the limbic system. And these fibers that relay in the limbic system, they provide a link between taste and pleasure. You know, the limbic system. So the taste and the pleasant sensations or unpleasant sensations, depending on what you are eating. If you are eating, for example, chocolate, then you will feel that you are you are satisfied, you are pleased. Okay. So this is this sensation because there are connections with the hippocampus, with the limbic system. Sometimes probably you have experienced that before, that you lose the sense of taste when you have a common cold, because actually the flavor of food depends not only on the taste, but also it depends on the smell. So you need to combine them together in order to feel the flavor of food. So what happens here in common cold is that the olfactory receptors are going to be blocked because of the congestion of the mucosa, and then you are going to lose this sense of taste. It's not, the problem is not with your taste buds, the problem is with your olfaction. So it's always, as I said, that the flavor is a combination of smell and taste. Like, for example, if you are asked to taste wine, for example, then part of the wine tasting is that you look at the wine and then you smell it and then you taste it. Isn't that right? So did I miss something? Okay, and then you toss it. You toss the glass. So why do you toss the glass? To hear it, so that you will use all your senses. You will use vision, olfaction, taste, and hearing. Now the last sensation for today is vision. So we have the eyelids. The opening between the eyelids is called the palpebral fissure. And on the medial side, which is called the medial angle or the medial canthus, there's a knob-like mucus area, red area, which is called the lacrimal caruncle. And this area on the medial side, it contains sebaceous glands and sweaty glands. And that's why when we wake up early in the morning, you'll find that there are some secretions from these like whitish crusts located on the medial side of the eye. Coming from these glands, they are from the sebaceous glands and oil glands, and sweaty glands on the medial canthus of the eye. And of course, the eyelids, they protect and lubricate the eye. This is why we blink. So we're always blinking, and it's not good that if you cannot blink, because this will result in dryness of the eye, dryness of the cornea. So we need always to blink to spread the film of tear in front of the eye. Which muscle causes blinking? Do you remember? It's oris is the mouth, oculi. So orbicularis oculi. This is supplied by the facial nerve. So people with facial nerve injury, they have a problem with that. They have to cover their eyes because they cannot blink. Then we have a very thin mucous membrane. This mucous membrane is called the conjunctiva, and it is usually described as a conjunctival sac because, in fact, it lines the eyelids, lining of the eyelids. So it is located here and located there above, and at the same time it covers the eye as well. So it's like a sac that is open anteriorly, and it covers the eye as well. So conjunctival sac, it's a very thin mucous membrane, transparent, but it contains blood vessels. And when there is irritation, these blood vessels will become congested. That's why we have red eye. It's because of the congestion of these blood vessels in the conjunctiva. Then the eyelashes and the eyebrows, they help to protect from foreign objects, perspiration and sunlight. And there is one type of infection here. You can see it. It's called stye. It's infection of, it's like a boil. The boil everywhere on the skin is infection of the sebaceous gland that is related to the hair follicle. Here we call it stye. It is infection of the sebaceous gland that is related to the hair follicle. And we have the lacrimal apparatus, which produces the tears, about 1 to 1.2 mil of tears every day. These are continuously produced, and you can see here in this diagram that the lacrimal gland, as a gland, is located in the superior lateral part of the orbit. You cannot feel it. It is inside the bone, but it has ducts. As you can see here, there are small ducts, lacrimal ducts. They open into the conjunctival sac, and so the tears are continuously produced. And while you are blinking, the film of tears is going to spread. If you put the tip of your finger on your upper eyelids on lateral side and close it, blink, you will feel that your finger moves medially. There is some medial movement as you are blinking, medial movement of the tip of your finger. And this is what actually happens, is that the fluid is produced in the superior lateral part, and while blinking, it's going to spread medially. And as it spreads medially, it is going to lubricate, and the excess fluid is going to be taken by two openings here, one on each lid, two puncta, two openings. If you haven't seen them before, then you can see them today on yourself in front of the mirror. Just lower down at least one of lower eyelid, and you will find that on the medial end of this eyelid, there's a small opening, black punctum located there. This is called lacrimal puncta, and there's another one superiorly, and they will drain the fluid to a lacrimal sac, a large area, a large sac here, and then from this sac, the fluid can drain by gravity through what we call nasolacrimal duct. As the name indicates, nasolacrimal means that it's going to end in the nose. That's why when you cry, then usually you sniff, because the excessive tears not only go on your cheek, but they will be drained by the nasolacrimal duct into the nose. And when you put in, like for example, an eye drop, then again you will feel it in your nose, and sometimes you will feel the taste as well as it goes back through the back of the nose and reaches the back of your mouth, because there is this communication. Some people have this ability. They can put fluid in their nose and then they just apply pressure. Of course, this is very bad to be done because it will affect the valves and cause infection. So they can just squirt or snort the fluid from their nose through their eye. The eye is like an eyeball, and it rotates in a bony cavity, because it's a ball that is rotating in a bony cavity. Therefore, the bony cavity is called the orbit, because of the rotation of the ball, so they call it the orbit. The orbit is the bone, surrounding bone, and the muscles that move the eyeball are called extraocular muscles. Yep. Pain. Okay. Yeah, I don't know, but definitely, definitely, it is. I would say that the limbic system is involved in that. Yeah. So like memories, affection, it will be involved in one way or another. Yeah. But there's no direct. You don't expect that there is a direct pathway in that. Yeah. Yeah. Good question. Yeah. You know what I mean? So the contact lenses cannot be repelled because they are not in touch with your blood. A rejection of any implant is done when there is because there's antibodies in the blood that will reject that implant. But here you are putting the contact lenses externally, not internally. Yeah. But even though, we will mention that in a moment, when you do a corneal implant, you change the cornea, sometimes is changed, even though because of it's very low vascularity, then the rejection of the implant, the possibility of rejection is very low. But for the lens, no, there is no rejection, because it's outside. It doesn't get in contact with the antibodies that are present in the blood. Okay? Yeah, good. So there are muscles, going back, there are muscles that move the eyeball, and these are called extraocular muscles. We don't only call them ocular because there are muscles inside the eyeball, as I'm going to talk about them in a moment. So there are muscles outside, there are muscles inside. The muscles outside are skeletal muscles, and as you can see them here, we have 4 straight muscles. We call them recti. So 4 rectus muscles, and 2 muscles which are oblique. So we have inferior oblique, superior oblique. We have superior rectus, lateral rectus, medial rectus, and inferior rectus. All these muscles are supplied by the 3rd cranial nerve, oculomotor nerve, except the superior oblique, which is supplied by the 4th, SO4 as a mnemonic. You can just remember that, SO4 for the sulfate. And the lateral rectus is supplied by number 6. So each one of these nerves, number 4 and number 6, you can see that it supplies only one muscle of extraocular muscles. They are very delicate muscles, and that's why there are cranial nerves, a lot of cranial nerves dedicated to them. 3 cranial nerves are dedicated to them. Even one muscle is supplied by 1 cranial nerve, like the SO4 and the LR6. The eyeball itself consists of 3 layers. We call them tunics. So there's a fibrous layer, there's a vascular layer, which is the intermediate layer. You can see it here. And the innermost layer is the nervous layer. We call it the nervous tunic, or the inner layer. We will deal to start with the fibrous layer, and it consists of the cornea. I just mentioned the name cornea here. This is the dome-shaped, transparent part of the fibrous tunic, not the white of the eye. The white of the eye is called the sclera, but both of them, they belong to the same tunic. So the sclera then anteriorly become dome-shaped, more curved than the sclera, and it's called the cornea. And look at here, at this junction, we call it corneo-scleral junction. There is a small duct, a small opening, a small canal. Just want to attract your attention to it, and I will mention it later on. So this is the cornea. This is the main refractory structure in the eye. The second one is the lens, but the main refraction that will reflect rays of light on the retina is the cornea. Okay, it is transparent because it's avascular and has regularly spaced collagen fibers. And as we said, that when it is, if it has like an ulcer, if it gets dry, if it gets injured, then it has to be replaced. And this is where we do corneal transplant. And these corneal transplants are usually successful. There's very low incidence of rejection because there are no blood vessels. And because there are no blood vessels, therefore injuries are difficult to treat. Okay? Because there are no blood vessels, then it is transparent. Then if it has no blood vessels, then how come it's going to be nourished? It's going to be nourished by either from outside, by the fluid, by the film of fluid, the tears that are present outside, or by the fluid that is present behind it, which is called the aqueous humor. We're going to talk about this fluid, which is present in this chamber, the anterior part of the eye, anterior compartment of the eye, aqueous humor. So it provides nourishment for the cornea because the cornea has no blood vessels. The blood vessels that you see, those are the blood vessels of the conjunctiva. Then we have the sclera. This is the white of the eye. Sclera means hard, like sclerosing, for example, means becoming hard. And it is dense, irregular connective tissue. It maintains the shape of the eye and protects it and provides for muscle attachment. You can see, for example, here, these are muscles. They are attached to the sclera so that they move the eyeball. So they protect, they keep the shape, rounded shape of the eye, and they provide muscle attachment. And as you can see that here, posteriorly, it is pierced by the axons of the optic nerve. So there's an area here which is like a disc. It looks like a disc for the axons of the optic nerve. That's why it is called the optic disc. So it is pierced by these axons. The optic disc is part of the inner layer, inner tunic, the nervous part of the eyeball. Now the intermediate layer is the vascular tunic, and this consists of three parts. Consists of the choroid, ciliary body here, and the iris. The iris is the colored part of the eye, is the iris. Ciliary body we cannot see from outside, and the choroid. The choroid is, if you look at the choroid on an actual eye, probably some of you have dissected an eye of an ox, or you will find that there is a layer that is black in color because it has melanocytes and contain melanin pigment. The reason is that this black part is to prevent the stray lights, prevent scattering of the lights inside the eyeball, so that the image will be sharp and clear. In addition to that, this layer is so highly vascular. It is important for the blood supply of the innermost layer, which is the nervous layer. So it is highly vascular, and it is responsible for what we call the red light reflex in cameras. So if there is no red light reflex, as you can see here in this kid, then you will expect that there is something wrong in his eye. Usually tumors of the eye prevent the formation of a red light reflex. If you go to this optional video, you will understand the importance of the red light reflex. Then we have, as I said, it's the choroid, it's the ciliary body and the iris. So here's the ciliary body. It consists of multiple processes. These are the processes of the ciliary body, which are located anteriorly. These processes, they produce fluid, which is called the aqueous humor. And then there are muscles inside. Inside the processes, you can see that there are smooth muscle fibers. That's why I said there are muscles inside the eye and muscles outside the eye. These are called the ciliary muscles, and there are these threads of fibrous tissue which are called ciliary ligaments or zonular fibers. They connect with the lens and they control the convexity of the lens. So you can see here, for example, the lens is not that convex, but here the lens become more convex. Having the lens becoming more convex means that it causes more refraction of light. So that's why I said that it's the cornea that makes the refraction to start with, but the cornea cannot change its shape. But the lens will do the fine adjustment because it can change its shape. How does it change its shape? Because it is connected to these fibers, and these fibers are surrounded by smooth muscles, which is called the ciliary muscle. If these ciliary muscles contract, then the fibers will become lax, and then the cornea will become shorter and more convex for near vision. Okay? If they relax, if this ciliary muscle relaxes, then the periphery will become wider, then the fibers will become more tense, and they will pull on the lens. The lens will become flat. So these muscles, I will just come to this point. These muscles are not related to the pupil. These are ciliary muscles. They are related to the lens. They change the shape of the lens, and you cannot detect them. The muscles that you can detect, thank you for this question, they are present in the iris. So what is the iris? Now we know that the iris is the colored part. It is the colored part of the middle tunic, the vascular tunic, and it is the colored part that we can see. In the middle, it's like a donut, flattened donut, and in the middle there is an opening which is called the pupil. This iris, it contains two types of muscle fibers. You can see it here, radial and circular muscle fibers, so that it can change the size of the pupil. And it's like in the camera, we have the aperture and the diaphragm. And in order to control the amount of light that is going to enter into the retina. So you can see that again in front of the mirror. If you look at the front of the mirror, you will find the size of the pupil. Then if you project light on your eye, you will find that the pupil become narrower, pinpoint pupil, to prevent excessive light from entering into the retina. Okay, so these are the muscles. So we have two types of muscles here, not only one type of muscle like in the ciliary muscle. We have a dilator pupillae, and these are radially arranged. So when they contract, they dilate the pupil. And we have the sphincter pupillae muscle, and so they are circularly arranged. So when they contract, they will make the pupil narrow. And this is the basis of what we call a pupillary light reflex. If you shine a light on the retina through the pupil, then the pupil will contract, not necessarily on the same side, but also on the other side it will contract as well. And these reflexes are actually, they are autonomic reflexes. So narrowing of the pupil is actually a parasympathetic reflex. Dilation of the pupil is a sympathetic reflex. When you have sympathetic overactivity, you are angry, then your pupil also dilates, so that you can see what is there around you. But sphincter pupillae muscle contracts when there is parasympathetic activity, or there will be no pupillary light reflex. Okay, like in a dead patient, a dead person, there is no pupillary light reflex. The pupil can also be used also for recognition, for biometric recognition. It's something like the fingerprints. Remember these ridges, the epidermal ridges, we mentioned about them. We said that they are unique in each person. Again, here, if you look at the pupil, you will find that there are ridges, there are folds and the crypts and ridges in the pupil. and these are unique, and they can use them to identify the person as well. Then we have the lens, and the lens is located posterior to the pupil. You can see it here. This is the lens. It's posterior to the pupil. It's avascular, contains proteins that are arranged like an onion. These proteins, they can change their shape depending on the tension of these fibers, the ciliary fibers that come from the ciliary body. And by this way, they can adapt for near vision or far vision. And in cases of cataract, where there is some deposition of material into the lens, this will cause damage of the lens fiber, and the lens will become opaque. As you can see here, it's not black, it's opaque, and the patient will look like as if there is fog over the eye. And again, the lens can be changed because it is avascular, so they can change the lens. Sometimes they use artificial lenses as well. Then the last tunic, the deepest tunic, is the nervous tunic, which is the retina. And you can see the retina through an ophthalmoscope. There's a special scope where you can see through the pupil inside the retina. So you can find like blood vessels that are present in the retina. You can see the redness of the underlying choroid. You can see an area here which looks like a disc, which is the entrance of the optic nerve. Of course, this area does not contain receptors, and you will expect that this area where the optic disc is located is called blind spot, because actually there are no receptors for light. No photoreceptors are located here. It's only the axons that are passing, and then just lateral to it there is another area where there is the sharpest vision is located. It is called the macula lutea, which has a depression that is called the central fovea. This is immediately in the visual axis, and it is where the sharpest vision is present. Also, the color vision is located here. In the retina, there are multiple cells. Some of them are the photoreceptor cells, and others are neurons. So we have pigmented layer containing melanin. It is not the same like the choroid, which is present outside, but again, we have more melanin here in a pigmented layer, again, to absorb the stray light. And we have photoreceptors. These are the photoreceptors. And then we have the bipolar cells and the ganglion cells. Three layers of cells. One of them is the photoreceptors here. And you can expect that light, I don't know why this is taking place, but actually the light will be passing through the retina, through all the layers of the retina, until it reaches the photosensitive layer. So the photosensitive layer, the photosensitive cells, they are not the first layer that will receive the light. They are the last layer. They are the deepest layer. They are the photoreceptors are two types of cells. Obviously, they are rods and cones. The rods are more numerous, and they are for dim light. So they sense different shades of gray, and they are present usually at the periphery of the retina here, that area. Most of these, they are rods. The cones, which are mainly for the color vision, they are for color vision and the bright lights. They are less numerous, and they are mainly concentrated in the region of the fovea, this area here, the fovea centralis. The fovea is actually, it's the depression in the region of the macula. And you can see that because there is depression, then light can go directly reaching the cones, unlike other places. And other places, the light has to pass through all the other layers. But here, because we only have the cones, then the light or vision becomes very sharp. These are the cavities of the eye. Inside the eyeball, we have the anterior cavity and a posterior cavity. The anterior cavity contains what we call the aqueous humor. And this aqueous humor is secreted by the ciliary processes goes into this chamber of the eye, which is called the posterior chamber. It's located between the iris and the lens, and then passes through the pupil to the anterior chamber, and then is going to be drained into this canal. Remember? Let me show that to you here. These are the ciliary processes. The fluid will be produced by them into the posterior chamber of the eye, posterior chamber of the anterior cavity, and then leaves the posterior chamber to the anterior chamber and will go to the junction between the cornea and the sclera, where there is a canal called canal of Schlemm. This is venous drainage. So there is always continuous movement of the aqueous humor. One of the functions of the aqueous humor is nourishment of the cornea, nourishment of the lens, because these are avascular structures. But what happens if there is a problem with drainage of this fluid is blocked? Then the fluid will accumulate inside the anterior chamber of the eye, and this results in increase in pressure in the eye, a condition called glaucoma. Okay, so that's the glaucoma. It's different from cataract. It's a problem with the lens. Glaucoma is a problem with the drainage of this aqueous humor. What about the posterior? The posterior cavity, it contains gel-like material, and this gel-like material is there since the embryonic times. Okay, it doesn't change, it doesn't circulate. That's why over time it will contain some debris, and some people, because of the debris that are present there, some individuals can see like floaters. This is one of the reasons like we have floaters. Okay, finally we will deal with the visual pathway. We have just mentioned that the sensory layer, the neuronal layer of the retina, is the deepest layer, and in that layer there are the rods and cones, and these are the specialized sensory cells. Also we have bipolar neurons, and we have the ganglion cells. It is the axons of these ganglion cells that are going to form the optic nerve. So here you can see these axons in yellow now. They pass through the optic disc. They are bundled at the optic disc. They come from different locations, and they form the optic nerve, passing through the choroid and the sclera, or the fibrous tunic. And here you can see the optic nerve, the second cranial nerve, leaves the orbit, and in the middle cranial fossa there will be partial crossing of fibers, partial decussation of fibers at the optic chiasm. The fibers now are going to form what we call the optic tract, and this optic tract ends in the thalamus. This nucleus in the thalamus, which has a special name called lateral geniculate nucleus of the thalamus, is responsible for vision, and it contains third-order neurons whose axons project at the optic radiation. This is an area of white matter here, you can see it here, called optic radiation, that ends in the cerebral cortex, in the visual area. This is what we call the primary visual area, and you can see that it is part of the occipital lobe of the brain. It's in the occipital cortex. Look at it here. This is the optic nerve, and this is another optic nerve. They cross where it looks like that they are completely crossing, but in fact only some fibers decussate across to form the optic tract. And then into the lateral geniculate body, synapse, and then the axons of the third order neuron will form the optic radiation that ends in the occipital cortex. So there is partial crossing of fibers, but there is a complete crossing of what we call the visual field. Look at the fibers here, the red fibers. They will receive sensory impulses from this side of the visual field. This is the right side of the visual field. And these fibers are going to decussate and go to the left side. On the other eye, on the left eye, these fibers, this side of the retina, also receives impulses, light impulses, from the right side of the visual field, although it is the left, but it looks at the right side of the visual field. And these fibers, as you can see, they are not going to cross, they remain on the left side. In other words, the fibers that are going to project to the visual cortex, they bring sensory impulses from the right side of the visual field if they project into the left visual cortex. And this same is true for the right visual cortex. So there is a partial crossing of fibers, but there is a complete crossing of the visual field. One side of the brain looks at the contralateral visual field. Thank you.